My name's Drew. I am going to talk very briefly, I hope, about a protocol for a cluster randomized control trial that will form the basis of my dissertation research. And so to keep in mind, this is sort of the outline of a pre-analysis plan. I very much appreciate your feedback, but I will, I suppose, because of time limitations, try to ask for comments to sort of wait until the end of the presentation. Let me start by saying some acknowledgments to my committee members, Will Dow, Paul Gertler, Leah Fernald, and Isha Ray, implementing partners who are working with this project out of Bihar, Anup Jain, Praveen Kumar, and Chandan Kumar, and Sangamitra Gouda, who's going to be working with me on the evaluation itself. And of course today, thank you very much, Madhavan, for spending your time to read everything that I sent you, and any comments that you are able to provide will be invaluable in the process. And thanks also to Beryl, Leach, and to Durgadas for all of his work, and Radhika. Thank you. Very brief outline of the project. I'm going to try to speed through some of the theoretical literature, but I'd like to focus a bit more on the situation of water in Bihar, my research question and hypotheses, and then we'll spend, I think, the bulk of the time talking about the study setting and some of the formative research that informs the design. The design is a very simple one for this project, and so, you know, finding ways to sort of attach bells and whistles are on my mind, but it's a very short time frame that we're looking at for this project, and so that's something to sort of preface this presentation with, because I think there's going to be room for growth and room for other aspects of this design further down the road, and so limitations and further considerations we'll discuss, I think, at a little more length. So I wanted to start this presentation with an embarrassing picture of me circa 1988, which ages me a little bit. My father, in rural Alaska in the early 80s, started a potable water delivery service. And so in communities in Alaska, basically municipal water is not always an option. And so delivery of this good is something that's been scaled up quite a bit in my home state. And so this sort of idea is near and dear to my heart. And I just wanted to embarrass myself a little bit and endear myself to you so that your criticisms are a little less harsh along the way. Okay, well, let me dive in. So you know these statistics if you work in the wash sector. There have been huge improvements in access to clean water worldwide. However, last mile access to the rural poor is still lacking throughout the world. 663 million people lack improved drinking water. 13 million of those in India drink surface water on a regular basis. And rural populations are particularly disadvantaged. So focusing on Bihar in particular, Bihar is a highly rural state. 88.7% by this census in 2011 lived in rural communities. Depends on your definition of the word rural. It's still very densely populated despite the lack of infrastructure and resources. In terms of water in the state, it's extremely water rich, at least in the Supal region of Bihar where this project is taking place. However, water during summer months is stressed. Surface water is highly vulnerable to biological contamination from open defecation, so bacteria, viruses, and protozoa. And this is just an example of a village that we drove through about a week ago in Bihar. So you can sort of imagine the disease vectors in this type of a situation. So in the 70s and 80s, the WHO, UNICEF, and the government had this policy to push for these mostly shallow wells to be built throughout parts of the state. Right now, around 94% of Bihari households use these mostly government-built public hand pumps. They are definitely the primary water source for the majority of residents. And they use it for all of their purposes. So the picture there, which you can't see very well, is an example of one of those pumps. And it's an improved pump, so it does sort of have that catchment, the paved surface. But there's a distinction here to be made between the deep bore wells and shallow wells. And so most of these are shallow in nature. Shallow wells are subject to chemical contaminants like arsenic, fluoride, nitrates, nitrites, and in this case there's quite a bit of iron in the water. A lot of this comes from mining and farming pollution from runoff. And iron, has the negative externality of poor taste and corrosion, as well as introducing incrustation of water surfaces, for potential further growth of biofilms. And then there are obviously negative health impacts on child growth and development from heavy metals. I mentioned the flooding and the inundation, and according to research that has been done in the area in the past 10 years, there is a drastic need for clean water education. 75% of households perceive their drinking water to be of good quality, while 14 report adequate awareness of purification techniques like boiling, treating, filtering, etc. This presents a significant burden for households in the literature. There's a little fuzzy area there in terms of some of the formative research that I conducted most recently. But the big takeaway here is willingness to pay. So folks really do view the government as responsible for provision of free, safe water. And because of the abundance of surface water and water in these hand pumps, there's an extremely low willingness to pay among people in the region. And so in interviews, there's a little bit of feedback. In interviews, the three most important factors that people tend to point to are that water is clean, tasty, and simple to use in terms of which they choose to use. So another study very recently by another PhD student at Berkeley looked at the study of water alternatives to a similar situation where there's a heavily arsenic and iron polluted shallow well water source as the primary use in West Bengal. And they found that in the last few years there's been quite a drastic increase in the number of small-scale independent providers that sell water, filtered water, back to communities in 20-liter jugs. They looked at the determinants of water purchase decisions, and they found that those that seem to drive those decisions are socioeconomic status, perceived likelihood of GI illness, and a dissatisfaction with the taste of iron, and that the perceived likelihood of illness and dissatisfaction with the taste were very highly associated with one another. So it was the same people sort of having the same concern on those two issues. They further noted that among those who do not purchase water through this mechanism, around 20% said that they would start to do so if the price were reduced to somewhere around 4 to 6 rupees per 20-liter bottle. So sort of framing the research questions here, there's not very much evidence on the impact of municipal piped water. It's hard to randomize, so there's a fair amount of quasi-experimental evidence. Likewise, with household water treatment solutions, there's a great deal of evidence, so it's much easier to randomize. There are a lot of studies. I don't want to spend a lot of time going into them, assuming that most people in the room have done that research and for time considerations, but what I kind of want to point to here is that water delivery as a potential solution to this issue of access to clean water is a bit of a middle ground approach. So it may help to sort of look at what would be the types of outcomes that you might expect under a municipal system, given that it approximates some of the benefits and convenience of piped water from a municipal system. It's possible to randomize, obviously. And to my knowledge, there's no RCT evidence to date on this particular mechanism for provision of clean water. It's not, however, a catch-all solution. It's not a silver bullet, and I think it's important to emphasize that early on in this presentation and in similar lines of research. It may provide a useful complement to other water treatment solutions that are already being rolled out at the household level. And it really is one of these sort of stepwise approaches towards full access to clean, safe water through a municipal pipe system. So in the absence of that type of a system, we need to examine a lot of these potential delivery mechanisms, and this is one that's growing in the market at any rate. And so that leaves me to the research question that I'm posing in this study. How can we try to incentivize the use of this type of product? What's the impact of price subsidies and potential health messaging on uptake of this type of a solution? and also on the continued use of the solution. So there's a question of, can you get people to buy it in the first place? Sure, but will they continue to buy it afterwards, and why? Secondary questions: what's the appropriate level of subsidy, and are there any sort of heterogeneous effects in terms of the length that you might offer someone a subsidy for this type of a program? And I'll get into that a bit more later. I'm going to skip through the literature because I don't want to dwell on it too much. Yeah, why don't we do that? I think the one study that I do want to point to is this study by Pascaline Dupont in 2014 that looks at the impact of short-term subsidies on either the increase or decreased use or adoption of insecticide-treated bed nets in Kenya. And what she was looking for in this study was evidence of either anchoring or learning effects. And so an anchoring effect is one in which a higher price that you pay might lead to higher or lower future valuation of a product. Meanwhile, learning effects would look at greater usage of products via zero cost. And so what they did in this study was to basically offer subsidies for ITNs, for insecticide-treated nets, at different rates, and then go back at the end of that period and look at adoption and willingness to pay later on. And they basically found that when you subsidize fully a bed net for the first time, there aren't these anchoring effects. There aren't these circumstances where people look at the bed net and say, oh, well, I got it for free before, why should I pay this for it? In fact, the opposite is true. People are more willing to pay for the product a year later than before. And so there were no anchoring effects found in the study. She speculates at the end of this study that the same may not be true for water treatment strategies, but she doesn't point to fully treated water. You know, it's not something that we tend to think about. And so I think there's potential here for that to for the results to be very similar in a similar setup, because fully treated water has a lower opportunity cost. It has a better taste relative to water treatment solutions like chlorine, and that's what we're going to go for. So I'm going to skip over that and talk a bit about the study setting. So SHRI is an organization called Sanitation Health Rights in India. Right now in the Supal region of Bihar, they operate 4 community latrines. In one of these facilities, the solid waste from the latrine powers a biogenerator, which pumps water up from a deep bore well. They UV and carbon filter the water, they chill it and bottle it, and then they sell it back to the community at a subsidized rate. This funds, in theory, local staff. Well, in actuality, it funds local staff to maintain the facilities, to basically sit at the latrine facilities as security, and to pump away waste in the non-biogenerator facilities. There's an upshot. They're looking at expanding these facilities across this region. They have a few more facilities in other parts of Bihar and in Jharkhand. So the water product that they're delivering here, 20-liter bottles, they cost 5 rupees per liter, so that's 10 rupees per bottle, and they deliver it in these jugs directly to families. So oftentimes, the stand that you see in the picture is one that they'll subsidize for families. They do also sell, or sorry, they do also sort of rent stands and bottles for an additional fee, but they found that that's been an impediment to a lot of families that they do want to serve, and so they tend to subsidize that cost. So it's not one that tends to get rolled up in the considerations. But in a cost-benefit or cost-effectiveness analysis, we would want to consider that. At any rate, they deliver on these 3-wheeled lorries. They have around 150 repeat customers, many of which are on the wealthier end of the spectrum in relative terms. About 50% of their deliveries are daily, and then they have another 50% that get deliveries on alternating days. So this is the location within the Supal region. The NGOs are in, or the sanitation facilities are in red, and the one that produces water is in blue in the bottom corner there. They serve predominantly agricultural communities. There's one of these facilities, as I said, that produces water. There's another one where they've discontinued water production because they were having a problem with demand, frankly, and they wanted to cut their costs. And then there's, like I said before, 2 sanitation facilities that are underway. So over the last few weeks, I've spent some time in Bihar with the organization, sort of talking about feasibility and conducting some focus groups across a lot of these communities. So sat down with some men's groups and women's groups separately. We looked at current consumers. We looked at non-consumers, people that may be interested in consuming. And then we had some mixed groups along the way. And we sort of tried to get a geographic spread here of different types of communities within the region. So I'm going to go over just the highlights of those focus group results so that I can move on to design. And how am I doing on time? About 15? Okay. Okay, so the topic areas that we covered in these focus group discussions, we were talking about households' primary methods of water collection, water treatment strategies, storage strategies, individuals' experiences with GI illness, and then knowledge about the organization itself, whether or not people were aware of the services provided, both for customers and for non-customers. So 3 slides of highlights. In terms of collection, treatment, storage, there's, as could be expected, very heavy use of hand pump water collection. Practically no one treats water. There are some examples of water treatment when a doctor advises a family whose child is sick, oh, you should really be boiling your water. And so once a child gets sick, they'll take them to the doctor will say that, and they'll boil for a little while, and then they'll go back to doing what they were doing before. Again, the number 1 treatment here is boiling, if they treat at all. And most families really do lack fuel for boiling, depending on where they are geographically located. There was a chlorine campaign some decades ago that people spoke about. Nobody liked the taste. It was sort of widely rejected. These were older folks that would bring this up. Younger folks didn't have any sort of experience with that. There were mostly women collecting the water, as the literature suggests, but I think because of the proximity of hand pumps, basically everyone has a hand pump. So the amount of time that gets spent collecting water is, I think, quite lower than what you would read in the literature. By and large, there's no storage of water, except sometimes before bed, people say they'll put it in a pitcher. And in some communities, the iron is so bad that the water actually changes color after its turbidity goes down. So there's quite a range of people reporting bad iron taste. In some places, it's not so bad. And even in pumps that are right next to other pumps where it's bad, it's quite good, people say. Okay, so health risks. People have very low levels of knowledge about health risks from what we've gathered. Most perceive that there's no problem with drinking water, but in sort of a case of cognitive dissonance, people simultaneously complain about gas, bloating, indigestion, loss of appetite, and they blame it specifically on the water that they drink. There's knowledge that bottled water is superior as a source in terms of health outcomes as compared to the hand pump water. And there's quite a disparity between wealthier respondents in terms of the understanding of health risks. So you've got people on one extreme living a mile away from people on the other extreme in terms of their level of knowledge. People perceive zero risk from cooking with well water, except for wealthy households. It's about a split. Some people were saying, yes, it's quite dangerous, and other people were saying, I don't see a problem, you boil it. Diarrhea is not considered a huge problem among most people that we've talked to, and very few make a one-to-one connection with the water that they're drinking. But there is a great concern about the health of children. When we talked a bit about willingness to pay and prices that people were interested in paying for water, the wealthiest individuals actually stated willingness to pay that was above the market rate. So especially very well-connected members of the community who tend to be the higher consumers, they looked at the NGO aspect of what was being done, and they said, you know, I'd actually be willing to pay 15 rupees for a bottle because I like what you guys are doing. So there's room to sort of leverage that possibility, I think, for the NGO. There's a sort of a mix in the middle of people who would rather be paying somewhere in the ballpark of 10 to 15 rupees or 10 to 5 rupees. And the very poorest of the poor migrant workers who are sort of working along the levy system, they absolutely are willing to pay 0 for their water. So let's see here. There have been some delivery issues with the NGO, sort of a hiccup that's happened over the last 2 weeks, and that's a little bit of a concern for fidelity of the design of this project. But I think it's something that's being handled. And I think one of the biggest takeaways from this whole process was the idea that when children who had gone off to school, say in one of the cities, and then come back, said to their families, stop drinking the well water. You have to drink filtered water. People stop and listen. So that's something that I think we can really try to leverage with our health messaging. So returning to the study design, these research questions that I touched on before, what's the impact of price subsidies on uptake and on continued use? And then some secondary questions, what's the appropriate level of subsidy, how much? And this question of anchoring versus learning effects. Can we try to disentangle that from a short-term subsidy program? And then there's this length question. And that's one that I'm a little less attached to because it's such a short study at the moment to begin with. I'd love to look at the difference between several months of subsidies and a very short-term subsidy program. Hypotheses. I'm at this point now where I feel that families receiving full subsidies will probably uptake more than those who receive partial subsidies, and then they'll potentially be more likely to purchase water after the subsidy period ends. So that's my prior, not a very, what's the word I'm looking for? Controversial one. And then there's this question of ex post take-up and dose response based on the amount of time that somebody spends in the program. And I would tend to think that those receiving the subsidies for a longer period of time, based on my prior of anchoring effects dominating, would be more likely to purchase for a longer period of time than those having gotten it for a shorter period. And so it's a very basic setup, randomized controlled cluster randomized controlled trial. Look at one arm that gets a full subsidy for varying periods, another arm that gets a 50% subsidy, so right around that 5 rupees sweet spot that shows up in the literature and in our own research, and then a 0% subsidy arm. And then we'll try to cross-randomize that with those who would get delivery for a shorter period, about a week, and those, given cost constraints on my part, the longer period being 2 weeks. But depending on funding and depending on some other questions, I would want to look at some longer periods of time there. So those are the prices that people would face. And very quickly, I think the order of operations here is important. This is an example of a coupon that a family might receive after listing has taken place. So we'd start with some household surveys and then a health messaging campaign, which I'm going to talk about immediately following this. And then after that health messaging campaign, one that's a bit community-based, one that leverages children who had, again, sort of gone off and learned about the importance of safe water, we'd have a willingness to pay auction. So in this case, probably a BDM auction, and I can go into the specifics of that later. But probably look at, rather than a single delivery price, one of these packages of delivery for a longer period of time. We'd do our listing and then we'd return and offer the subsidy at a lower rate. And then end line, families would basically be randomized into one of these two groups, 100% subsidy or 50% subsidy. And at the end of the period, we'd come back and we would offer a one-time purchase at 50% subsidy. And the idea here is to basically try to look at these anchoring versus learning effects. And so let's say this is take-up at time 0 before the subsidy starts. We sort of presume that families are going to uptake the partial subsidy group at a 20 to 30% rate, as we might expect from the literature. Those who would be getting it for free are probably close to 100%. So what happens in the second period? Under anchoring effects, that full subsidy group would get offered a 50% rate, and they'd say to themselves, well, I was just paying nothing, so why should I pay anything at this point? We would expect the partial subsidy group to uptake at about the same rate that they were before. They're getting a discount. So under anchoring, we might see an outcome somewhere along these lines, and under learning, it would be the opposite. So the full subsidy group might end up uptaking at a slightly higher rate. So that's the outcome of interest. This is a little too confusing to get into the weeds of, but the idea of a dose response, depending on the amount of time that a family spends, either a week or 2 weeks or longer, hopefully, fingers crossed, might give us a little bit more to talk about. So some more research questions that I think are worth considering. What's the relationship between willingness to pay and uptake? What are the strongest determinants of uptake and of continued use separately? So what's really driving these decisions? Is it wealth? Is it child health status, the rate of stunting within families, within communities? So are families looking at their children and perhaps looking at their neighbors' children who are bigger and thinking, oh gosh, like maybe I should be doing something different. So community health stat, potentially whether or not neighbors treat water or purchase water rather, and whether your children have some sort of a role in this messaging campaign are things that I'd like to be able to leverage. There is this study by Kramer and colleagues that looks at the impact of a whole package of price subsidies and persuasion campaigns on a water treatment program in Kenya, and they found some mixed results, but one of the things that jumped out was using local community members to promote chlorine was actually highly effective at getting people to use chlorine. And so, again, just sort of pointing back to that, I think could make for a very interesting way to design that part of the campaign. Okay, so a few limitations and considerations that I'm going to bring up. There are more. I invite them. Families very specifically mention that if the water that they receive from delivery is not cold, they're not going to drink it. They'd rather drink water from the pumps, especially on a hot day. So this necessitates frequent daily prompt delivery, and that's something that we're going to have to work very hard with the implementing partner to make sure happens. There's a risk theoretically that families may sell water to other households if they've had it fully subsidized for themselves. I'm not as concerned about this. For a number of different reasons, not least is that even in the literature we don't see examples of that with health products. So if it's marketed properly, it's also a very short-term period. It's something to consider. There's obviously an issue of unsmooth incomes. Agricultural workers, are probably going to be liquidity constrained, and then there's some misuse of containers potentially. I'm going to wrap up here with, subsidy period. Okay, again, I've talked about this ad nauseum. What's the proper length in which to roll this out? Should families be paying full price up front versus an option for pay on delivery? Right now, families are paying when the water guy comes around. And I think that's to their detriment, and that's to the organization's detriment. If you were to pay for a package, if you were to pay for a week of deliveries, a subscription service, I think that you're looking at potentially a much higher uptake rate. People don't have to sort of cognitively think about it every time they want to make the purchase, and they don't have to rely on the guy showing up when they happen to be there. It's going to be dropped off to their door. liquidity, again, is going to be a problem. But I think that moving towards a subscription service is a much better option. On the follow-up, yeah, I'll talk about my next steps. So right now I'm still fundraising. We're looking for even just a few more small grants at this point would sort of help to push this over the top to make this project a reality, and then hopefully be able to partner with a few more organizations. I think there's room for complementarity with water treatment solutions. I think it would be sort of a fascinating exercise to see how subsidies for fully treated water combined with smaller treatment solutions might increase fidelity of use of clean water among these families. So that's something that I'm thinking a lot about and hoping to talk to people too about. Let's see, I have a little bit more work to do to determine exactly how much water we can produce for this project. I think we're going to be able to get a large enough N, so I'm not too worried. And of course, Radhika, of course I'm going to pre-register this study along with the pre-analysis plan on the RIDE website, and I'm also going to do it on the AEA website, because why not? That's about all I have to say. So thank you very much for taking your time today. I appreciate it.